I want to introduce Dr. Nadia Merchant, who will be speaking on endocrinology and myotonic dystrophy. Dr. Merchant is a pediatric endocrinologist and geneticist, as well as an assistant professor of pediatrics at UT Southwestern and Children's Health in Dallas. She also participates in a number of multidisciplinary clinics, including the MDA Care Center at UT Southwestern, Bone Clinic, Skeletal Dysplasia Clinic, and General Endocrine and Diabetes Clinic. Dr. Merchant, thank you for being here today, and I will turn the time over to you.
Thank you for having me. Let me share my screen. There we go. We're good.
I cannot see your screen right now.
Okay, let's see. Can you see my Can you see my screen now?
Yep,
Perfect.
I see your presentation.
Thank you all for having me. I'm going to talk about endocrinopathies and myotonic dystrophy. And really, I would love to hear some questions people may have since I know we were talking about clinical trials, and this is more about what can we do to help from an endocrine standpoint, because this is a multidisciplinary condition. So we're going to explain how myotonic dystrophy can affect the endocrine system, outlined recommendations like for monitoring, diagnostic testing, and screening protocols, and really empower patients and caregivers with information and resources to help them make some informed decisions. So one of the questions that I believe were already sent earlier was, do I need to see an endocrinologist and why? I think the first question starts off as who is an endocrinologist? Because many of you know the neuromuscular physicians, maybe have seen a neurologist, but you may not have really seen an endocrinologist. And so, kind of, what do we do? An endocrinologist is a physician who specializes in diagnosing and treating conditions related to hormones. And in that, we have many different types of conditions that we can think about. Is it really the organ itself involved, or is it really the pituitary that's in our brain? Is that involved? And hormones are regulation, and so we kind of think about like where did the regulation go wrong, and can we replace the hormone? That's more of a really simplistic definition. So we were just talking a lot more detail about myotonic dystrophy, and there's some prevalence data that varies, but it's most commonly an autosomal dominant. It is an autosomal dominant condition with most commonly adult onset, but it does depend for some when the presentation occurs. Most commonly, it can present at birth to old age. Most present around the 20s to 40s, and then children may present with some cognitive and behavioral issues rather than muscle weakness. But there are lots of major symptoms, and endocrine makes it to the list of all the symptoms that are there. So this is just one kind of looking at some of the clinical features and if some of for DM1 versus mitochondrial dystrophy type 1, 2, and how there is an overlap. We do know that more prominent in mitochondrial dystrophy type 1 versus type 2, but you can see them in both. And so some of these features like insulin resistance and testicular atrophy, which I'm going to go into more detail, but there is an overlap in for both for the conditions, and endocrine is included in both. And I think that the most important thing that I would like to emphasize, and why I've been part of a lot of multidisciplinary clinics, is that we really need a multidisciplinary approach for these patients, for patients with myotonic dystrophy, or really just even any neuromuscular condition, because they have so many other systems that are involved, including the GI system, the heart, and then endocrine. So now let's kind of go more into focus on the endocrine glands that are affected. We know that the end organs itself are affected, so meaning the gonads, the testes and the ovaries, the bone, parathyroid, the thyroid, diabetes, and adrenal. And I'm gonna break it down into like specifically each one, because then we know what to screen for and what should you be looking out for and what we can do to help. And so, but really, we know that the DMPK mRNA is expressed not only in muscle, but it is expressed in the testes, ovaries, pituitary, thyroid, and liver and bone. And that's why we know that there are presentation of all of these in the different endocrine organs in a sense. So let's start off with testes and ovaries, but specifically I'm going to start with male hypogonadism. So I'm going to kind of have a little bit of this table where I describe each endocrine disorder, some of the key findings, some labs that may be ordered for you, and then recommendations that could be given. But let's specifically start with understanding what is it that we look for in the testes. Um, Most frequently, the endocrine manifestation that we see is primary adult testicular atrophy. And that's the one that's been discussed the most in general, is talking about the testes size can be very helpful. So on exam, they might have slightly smaller testes, and then when they do like testicular biopsies, they've seen that sometimes there is abnormalities in the sense that there is some germ cell maturation arrest, or there's abnormalities in the way in where the semen, in the sense with sperm, are coming out from, and it can be a really variable phenotype. As we know, myotonic dystrophy is very variable. In general, oftentimes people don't think about testes because pubertal development is generally normal until they get later on to adulthood. And as they maybe then the body hair itself may get decreased. But in general, in no puberty, they usually have a normal puberty. Some can have gynecomastia, but gynecomastia in general is more common than we talk about it. But it has been mentioned. What happens is that the sperm production and quality are impaired, but many married hypogonadal men will have reported previous fertility, meaning it's not that they are not fertile in the sense, it's just that over time they may develop like a decreased sperm count, and the testosterone in a sense may be affected. And I'll go into a little bit more detail. From our understanding that the DMPK, as you have more CTG repeats, basically from there, it leads to the abnormal splicing, and it affects the way the sperm production occurs. And then that indirect and everything in endocrine and sense is a hormone is a pathway. So one affects the other. So then you could have decreased testosterone. You could have Leydig cells and Sertoli cells being affected. And really all that basically tells you is endocrinologists can do some hormones to get a better idea of what is going on and what to look out for. There is some debate on whether how much is correlated based on how many CTG repeats. There was one specific study that was done. It's a retrospective like a study where they looked at data of patients that had been followed for myotonic dystrophy type 1, and based on the number of CTG repeats, they saw that basically the more repeats you had, the more expansion in a sense, the age of presentation was higher, and the amount of patients that had hypogonadism or low testosterone or lower fertility, sexual dysfunction was higher in the population with more expansion, and it presented earlier. There are others saying that there is some studies that showed that there was no exactly testicular dysfunction correlation with CTG repeat, but there's a couple studies that have showed both ways. So I think that it is helpful data to have as we're looking at our patient population and how many. But you can't say one versus the other is definitely correlated completely. So in general, we do know that men with myotonic dystrophy are at risk for hypogonadism. They could have lower testosterone. They could have difficulty with fertility and some sexual dysfunction. There are labs that we can order. Sometimes it starts off with just having the labs done by your neuromuscular physician, obtaining an FSH, LH, or a testosterone level. And then there's some further evaluations that may be done by the endocrinologist to get a better understanding. And then you and then they look and in some places there's discussion about whether to replace testosterone as indicated, but we do know that if we replace testosterone, that can also suppress the sperm count even more, so there needs to be good discussion regarding that. And then there is when talking about treatment for erectile dysfunction, there is some concerns for cardiovascular risk, so you definitely want to be talking to regarding if you want to do anything for that in a sense. So that's why a multidisciplinary approach is really recommended. Regarding testosterone treatment, so men may have lower testosterone, and studies have shown that adult men with myotonic dystrophy did have increased muscle protein synthesis. And if you treat that when you treat testosterone, you have increase in muscle protein synthesis and fat-free mass, but it did not increase the maximal like voluntary muscle strength in general. So they're also they're the lower testosterone levels in men can cause is associated with decreased muscle mass and strength, but muscle mass in men in general did not like was unrelated to testosterone levels. So there like testosterone treatment is used, but it can also suppress their sperm count. So you want to make sure that when we're having that discussion, what are our end goals and what are our expectations and what you expect from the sense of testosterone treatment. And also, that doesn't help. In some people with testosterone who have low testosterone, they may see better outcomes compared to those people who have myotonic dystrophy. But it is something that is done in patients with myotonic dystrophy, and it just needs to be a good discussion with your endocrinologist and your neuromuscular physician of why you're doing it, what dose we're doing, and what the expectations are. So then let's go on to females in the sense for ovaries. There can be some female reproductive dysfunction. Usually, the females have normal ovulation and fertility. They have some increased pregnancy complications for those that have myotonic dystrophy. When they get labs done, so there can be slightly elevated FSH and lower anti-Müllerian hormone, which is checked for seeing what your like how many like in the sense of your eggs and like of ovulation. But it really generally it's not as severe as it is in men, and there's not as much of a concern for fertility in females. But genetic counseling is really important for in discussing other options because um, even though the female reproductive system is less affected in primary ovarian dysfunction, if there's elevated FSH and low anti-Müllerian hormone, you may want to discuss what needs to be done and whether IVF may be something that needs to be done for that because you may not have as many years of fertility in a sense. And so you can have ovarian dysfunction as you get older. There are also pregnancy complications in general for females who have myotonic dystrophy. So being able to follow closely with your OB if you're pregnant, and also that myotonic dystrophy patients are at increased risk themselves for respiratory suppression by anesthetics and opioid drugs. And so those are things that you want to be discussing about your own health if you're affected and you are pregnant. So that is something for females. I think that it's important getting labs just to get an idea of where your FSH and anti-Müllerian hormone would be helpful as you're being for more of a screening perspective to know whether or not there is concerns or not. But if you have regular periods and everything is going well, then the question is really how often do you screen? There's not any specific recommendations at this point. Um, but one thing I will bring up is genetic counseling. There's now, I mean, for when you have when you do have myotonic dystrophy, and whether or not there's options such as IVF and pre-implantation genetic testing for couples that are planning to have children because there is a repeat expansion repeat for generations, especially for the in the sons of affected mothers in whom massive expansion occurs. So that is a good discussion to have with a genetic counselor as you're thinking of conceiving. So that's kind of in a nutshell about ovaries, testes, and the kind of how, and also genetic counseling. I'm going to move on to diabetes and insulin resistance. So that's a completely different kind of hormones that we think about. We do know that there is increased insulin resistant diabetes, and they can have the non-fatty liver disease or elevated ALT and AST, or NASH as we call it. So the recommendation is to get an annual A1C of fasting glucose and a lipid panel. And so that way, that we can change the diet if needed. And that way, and there's also discussion about whether or not you can do medications if there is insulin resistance. Some of the studies haven't been the greatest regarding metformin, but if you have diabetes, then metformin may be one of the drugs or thiazole, the adenoids. There's different medications based on how severely you're affected. But the risk of diabetes which is type 2 diabetes, is about fourfold more than the general population. And the prevalence is about 20 to 80%. Now, the age of that can vary, like later, just you may be presenting earlier than you would have presented if you did not have myotonic dystrophy. The features include hypertriglyceridemia and low HDL, which is like the good cholesterol. Blood pressure tends to be pretty normal in most patients. And there's also been leptin is not something that we do all the time in a clinical sense, but the studies have shown that there's higher leptin levels in myotonic dystrophy males and females when you look at the matched BMI, which kind of is one of the signs of also insulin resistance and our appetite and everything else. But that's just more about a study perspective. But it's generally important that you do screen annually for A1Cs as you get older to make sure you don't get diabetes. But diabetes treatment is just the treatment that is needed based on what type of diabetes you have and how severe you are. Um, and there's in the 2018 study that they did for metformin, they did not, metformin had shown to improve the 6-minute walk test, but did not affect muscle strength and myotonia in some of those studies. So we just generally, I don't think we would put somebody on metformin just because they have myotonic dystrophy, but really if they have signs of insulin resistance that we're seeing. And you do want to treat the diabetes because it can affect the heart and it can affect more, exacerbate your muscle weakness. So to just summarize, for insulin resistance and diabetes, you want to be able to get an annual A1C, fasting glucose, and a lipid panel because that can help with being more preventative and more aggressive on making sure we're managing that appropriately. Next, I'm going to move on to calcium metabolism. So PTH, calcium, and bone disease in general, I kind of put them together because calcium's in our bones and our parathyroid hormone helps us regulate our calcium levels. And we see the key findings we see in patients with myotonic dystrophy are elevated PTH levels, and there's increased risk of vitamin D deficiency. So the recommendation is to follow serum calcium levels and test for vitamin D deficiency. And not how specifically how often do we do that? There's not clear guidelines, but there is that you want to periodically do that, especially if there's concerns, because calcium is essential for muscle strength, structure, and function. And our parathyroid hormone really helps us regulate the calcium levels in our blood and in our body. One of the things that we do know in myotonic dystrophy is that there is a slightly higher risk of a parathyroid adenoma, which is makes excessive amount of PTH, which can take the calcium out of your bones in a sense and put it into your blood to maintain the levels in a sense for you. And so we do know that there's slightly higher risk than the general population. And if you have untreated parathyroid adenoma for a long period of time, then that can lead to lower bone mass. So I'm just going to talk about in general, as we're talking about, some people had asked about what to do since you're for kids. But in general, remember, our bone bank is built really, really early in life. We start off with a certain amount of bone density. We build up that bone density while we're in puberty, and then it's really just all downhill from there. And so what we want to do is we want to optimize our bone density as we're going through puberty and childhood. And that is including by having enough calcium in our diet, staying as active as possible, and then maintaining it by staying active and keep making sure we take enough calcium and vitamin D in our diets, or through vitamin D through sunlight, depending on, but not everybody can get enough through sunlight, and that's why supplementation may be something to be considering, or a multivitamin. So what I think about is skeletal risk factors in general, like what will lead you to have a fracture in the long run or develop osteoporosis earlier on is if our hormones are affected and if we don't go through puberty appropriately. If our nutrition and our diet does not include enough calcium and vitamin D. Now, foods like orange juice and milk are fortified with vitamin D and calcium since the 1930s because we knew that rickets or vitamin D deficiency, low calcium, was a risk. And so we have a lot of foods available that are fortified. So, but if people are lactose intolerant or they don't want to have milk, oat milk that you buy at the store also has plenty of calcium and vitamin D. And so making sure that you get that through your nutrition and your diet is important because you want to have strong bones, especially because the muscles and the bones work together. And so you want to make sure you can have strong bones as much as possible. And then physical activity as much as possible, making sure that we can stay as active as possible because we our sensors tell our bones build bone, or maintain the bone we have by putting weight by being weight bearing. So for example, swimming doesn't increase your bone density or maintain it, but walking does. And so those are different things that we try to work on. Steroids, which more in Duchenne muscular dystrophy, which is a regular with the daily treatment that they're on, has a negative impact on bones. And so there's things that can affect our bones or medications that you may have. But also knowing if you have a family history of fractures, if you've had early onset of hip fractures and grandparents, or that may put you at a slightly higher risk. And so thinking about your bones, and how do we maintain and have strong bones goes a long way. So what is a parathyroid adenoma? So on our thyroid gland, we have four parathyroids in there present. And what happens in parathyroid adenoma is that one of our parathyroids make too much PTH, which causes our calcium levels to be affected and to go up. And then the other parathyroid glands itself kind of don't work as well because they don't need to. And so you remove the parathyroid if there's a concern, if there's one parathyroid item that's identified, and then for a period of time we'll have to do some calcium replacement till the other parathyroid glands wake up. So that's usually what we see in myotonic dystrophy when you have elevated PTH, but you could have secondary parathyroid hormone also elevated. But generally, it's not parathyroid hyperplasia where all four of them are really active. It's usually one or that is more active. And so that's why screening with labs such as calcium, PTH, and a vitamin D level periodically would be helpful so we don't miss out on that because your calcium affects the way your muscles function, and you want to make sure you're not deficient or being affected in that way. And then optimizing vitamin D, making sure you're taking enough vitamin D in your diet is important so that way we can maintain strong bones is also really important. Now, if you do have slightly elevated PTH and you identified that you have a parathyroid adenoma for a period of time, they may tell you not to take as much vitamin D until so that way your calcium doesn't rise too much. And then eventually you can go back on it. Next, I'm going to move on to thyroid. There is reported prevalence of elevated TSH in anywhere from 6 to 13% of patients. In one study that was done in France, about 45% of patients had thyroid peroxidase antibody that was positive. But in general, I mean, there is a there is like the thyroid itself can be 1 in 8 females, for example, has thyroid issues. So it's not that it's in a much bigger than we do see more elevated TSH, but I don't know if I would say it's significant. On the other hand, the likelihood of a benign or malignant thyroid nodule appears to be slightly increased. They're saying that there's maybe about a 10 times more increased risk than the general population. So based on these results, the screening for thyroid ultrasound, as well as testing for thyroid dysfunction has been recommended. And so the recommendation is to really just test the TSH and the free T4 levels, maybe consider doing a thyroid ultrasound, especially if you feel something in your neck that feels like a nodule, then definitely doing a thyroid ultrasound would be something to recommend to screen for the thyroid. But also thyroid, if you have hypothyroidism, you may have symptoms. So you may be having unexplained weight gain and feeling tired and fatigue, which may lead to some of this, may lead to getting the labs if there are concerns. The next organ that's been reportedly affected is the adrenal cortex. Despite there's some hormonal changes, there have been some levels that have been stated that people have higher ACTH and lower DHEAS, but there's not any known increased risk of adrenal insufficiency. And our adrenals are important for our stress response. So if we get sick, we should make more cortisol. And when they have when they've done studies to see if do you make enough cortisol, generally these patients do make enough cortisol. So even though the labs seem slightly off, they seem to be appropriately responding to stress. So this is not really something that we focus on in general in myotonic dystrophy. So to summarize, I think that this seems a little bit overwhelming, but I think endocrine cat may play an important role, part of your regular management of endocrine may play a role in your management for myotonic dystrophy, especially for those with myotonic dystrophy type 1. And because there's a risk for insulin resistance and diabetes, there's risk for elevated PTH levels for those who have a parathyroid adenoma, they may be, or if they develop thyroid disease. And then especially for males who are at higher risk for hypogonadism. So I think that leads me to the question of how often should you see the endocrinologist? What can the endocrinologist help you for? And it depends on where you are and who you're seeing. Some may have your multidisciplinary team may have you do labs regularly, and if the labs are abnormal, your endocrinologist. You may establish care once and then have your annual screening labs done. And then if there's any abnormalities, then you see your endocrinologist. So I think that everybody takes a little bit different approach and be depending on how severe and how many of the expansion repeats, does that make a difference? Those are all things that I think as we do more, I think more studies and more information may be available. We may have better, more specific guidelines. But the way I think about endocrine is a lot of this stuff are symptomatic. So hopefully we can catch them sooner than later. And we can treat appropriately based on what we have deficiencies for or affected organs. And that leads me to like what questions do people have that I can answer for myotonic dystrophy and endocrine.
Thank you so much, Dr. Merchant. Sorry, my buttons seem to be pausing here. Thank you so much. It didn't look like we got a ton of questions, so for everyone in the audience, feel free to continue to type in your questions, and we will go over those. Let me just go ahead and share my screen. All righty.
So, okay.
Can you see my screen?
Yes, I can see your screen.
Okay, perfect. All right, so you addressed this in the beginning. Is an endocrinologist a must-have specialist within myotonic dystrophy? But just to add to that question, if that's not someone you've been referred to yet, or if they don't have one at your care center, is that something that you should seek out or speak to your doctor about, or should you just wait until you get a referral?
So I am a fan of meeting with an endocrinologist. The question comes down to when do you see them? And so because if you had screening labs done by your specialist, your neuromuscular physician, you may not need to see them right away. The question really comes to as how comfortable is your neuromuscular physician also about speaking about the endocrine related conditions. The reality is myotonic dystrophy is not as common, and endocrine has a busy clinic, and your endocrinologist may not even know what to screen for. There are some great papers out there about what screening and what to look out for. And so my goal is in some ways, this is to help you go to your endocrinologist to be like, these are all the different conditions I think I'm at risk for. How should we screen for them? So because I wish there were better guidelines, and as I was reading more, I was like, these guidelines could be better. And I think the question is, well, we don't want to overtest either. And so, but I think if you feel, I think that you never go wrong by going and seeing a specialist once, especially when you have a complex condition, because then if suddenly does go something isn't right, you have somebody to go for too.
Absolutely. Thank you. Um, you talked a little bit about reproductive health. So someone said, if a male has myotonic dystrophy 1, can it cause his wife to miscarry?
I don't know the answer to that. Um, I guess it depends on the expansion, but I don't know. Honestly, I'm not gonna I don't know if that is an increase.
Okay, nope, that's fine. Thank you. Um, this person asked any data on hypothyroidism for DM2.
So there is not as much data on DM2 for endocrine related. I what I will say that especially when it comes to some of these conditions is that hypothyroidism is common. If you have autoimmune in your family, you're at higher risk. So I don't even know, and maybe if you have myotonic dystrophy, you're even slightly higher risk. But in general, I think if you got your thyroid labs checked, a TSH and a free T4, and they're normal, some people, if you're really concerned, I would say maybe consider getting your thyroid antibodies checked, which just tells you if you're at much higher risk compared to the general population, maybe something worth considering. But there's not a lot of data out there on what about DM2. But if you're feeling tired and fatigued, which you may feel with myotonic dystrophy in general, getting thyroid labs can be reassuring if they're normal.
Great, thank you. Next question. I have found it very difficult to get an appointment with an endocrinologist. The wait is 6 months. Any suggestions?
If you're an adult endocrinologist, the 6 months is pretty good. In a pediatric, sometimes I think it's about a year. There's a shortage of us. And so I think that's what makes this really challenging for me to say everybody should establish care for an endocrinologist. And so I think that there are screening labs. And then if the labs are abnormal, then we can always all phone a friend. And so I think that the question really comes down to is when you do have something abnormal and you're really established with your neuromuscular physician, I think that if there is something really abnormal, they'll get you in. And that's why I think establishing care with your local endocrinologist. If it takes 6 months to get in, at least you've seen them. So if then they may say, come back to me once a year. And then if there's labs abnormal, then you'll see them sooner. I think that's important. I mean, but yes, we could have more endocrinologists in general, I think.
Sounds good. Thank you. Um, I hope I'm pronouncing this right. So it says, I have a neck goiter, Goiter, which has been fine for years, but now there is a node in there. Should I get a biopsy done or just watch it if it's small?
So there are, depending on what the goiter is, I would talk to your endocrinologist and see what they would recommend. It all comes down to the size, whether you have an autoimmune antibodies that are positive, whether to do a biopsy. But a biopsy is pretty common, or an FNA with fine needle aspiration is quite a common. It also depends on if the node there is like if it's dark, or dense or not, cystic, that makes a difference. So, based on everything, I would just say talk to your endocrinologist or to see what they would recommend.
Sounds good. Thank you. Is it likely that my myotonic specialist would notice any of the things I could be at risk for related to endocrinology?
So, Um, so I think that it depends. I think that we could always increase the awareness of a lot of the endocrinopathies that are existent. Um, I do know that some of the myotonic dystrophy physicians will order some annual labs. So they wind up getting maybe the A1C and lipid panel. And if those labs get flagged, that's when they refer. So I think maybe having a discussion with your DM specialist saying like, what do we do to make sure I don't have any endocrine issues or GI issues? Or do you feel comfortable that you are screening for these and they refer me appropriately? I think a lot of it comes down to where you are and who's your ringleader, as I call it. I think your DM specialist is your ringleader, and they can kind of go from there, helping you decide what needs to be done.
Great point. Thank you. Um, we can do a couple more, so keep entering in questions if you have them. How does myotonic dystrophy impact metabolism, and should I be aware of any specific dietary considerations?
So I think that based on knowing that there is an increased risk of insulin resistance, which is more like type 2 diabetes, um, I think that a healthy lifestyle is really important. And so there's so if we can work with making sure you're eating a relatively healthy diet, if you can be as active as possible, those are all things that we can do. They're important, but also remember half of Americans in some places are overweight and obese, and we know we're seeing more and more type 2 diabetes. And so I think that that's in general population, I would say, yes, it's healthy lifestyle and eating, portion control, food and beverages. These are all things that everybody can work on. And it's always, I think, healthy lifestyle is a roller coaster ride. We do better, and then the holidays come around, and then we wind up eating a few extra cookies, and then it's again, we have to get back to the being a little bit more cognizant of what we're eating. Now, that doesn't mean that you need to go on a strict diet. I think that's really causing for burnout. So, I think that is finding that right balance.
Perfect. Thank you. Um, are there lifestyle changes or treatments that can help reduce the impact of endocrine symptoms in myotonic dystrophy?
Um, I don't think that there's much. I think screening, I don't know if there's anything really specifically to say to Jill. Yeah, I don't mean like I mean, I think we can screen for them living a healthy lifestyle. That's important, but I don't know if there's anything that is specific that we know right now that we would be more do.
Great, thanks. And just again, we've gone over the question about should you see an endocrinologist, but how often? Do you have a suggestion for how often? I know you talked about getting screenings.
So, I think it depends on, so that's a little bit depending on how severe your myotonic dystrophy is in the sense, and also depending on if you have any active issues. I mean, if you have any active issues, I think that your endocrinologist will see you appropriately accordingly. If for example, if everything looks good and you've had no screening, if you've had all your screening has been normal, they may say, I'll see you back in 18 months or 12 months and we can repeat the labs again. So I think that it's hard to, and I think that's why we don't have exact guidelines because we don't exactly know when should we see and how. But sometimes, in for a lot of different conditions that I follow, even some things as simple as like Down syndrome, where we know they're at increased risk for thyroid disease, we let them get their thyroid labs done every year or based on our screening recommendations. And if they're abnormal, we have them come see the endocrinologist. I think we all are really busy people, and even if you have myotonic dystrophy, you have a life of your own, and nobody wants to sit and wait for a doctor's appointment and be told that there's nothing wrong. And so the question really comes down to is like what is the right balance for each individual and what makes them feel like they're getting everything right. So we're maybe seeing an endocrinologist, having a discussion, what do you need to look out for, what symptoms, what labs, and then decide when you need to come back. And it may be a different discussion based on where you are and who you're following with.
Great points. It looks like we just have a couple more questions here. Should I be concerned about adrenal gland function, like cortisol levels, with myotonic dystrophy?
So as far as the studies have shown, no. So the labs, when they did some hormone levels, they saw that they were slightly abnormal, but when they checked to see whether they had enough cortisol for a stress response, it was normal. So there's no known adrenal recommendations or concern for adrenal insufficiency. Now, I will say there's a lot of there's a lot of people who talk about adrenals on TikTok videos and all of that, and I don't know what to make out of that. But there is generally, I would say, we don't know. It's not that a known correlation that you have adrenal insufficiency, meaning you can't produce enough steroids if you were to get sick with myotonic dystrophy, as far as I know from right now. Now, if new research studies come out, I mean, it might be otherwise, but that's far as I understand.
True, thank you. And then final question, how do endocrine treatments such as hormone replacement therapy interact with myotonic dystrophy?
So depending on what treatment you are, so if you have hypothyroidism, you have a low thyroid, you're going to take enough thyroid to get your thyroid hormone levels in the normal range. You don't overdose on it in sense. So I think it should really improve your overall. So if you don't want to have untreated hypothyroidism because that's going to make you feel worse. So if you treat it, you should have those labs done regularly. And our goal is that we treat them to get your thyroid levels in the normal range, and that shouldn't affect your myotonic dystrophy. There is some studies which I kind of touch base on testosterone. I think it's knowing that when men have lower testosterone, what do we consider low and what do we want our goals to be? Because testosterone levels that are normal can vary from being like 400 and to be 1,000. And like we want to make sure that we're on the right dose of testosterone. Are we doing testosterone replacement or are we giving a lot more testosterone than we need that may also have negative impacts? And so I think those are all important discussions about what's our endpoint, what's our goals of our treatment. The main thing I would say is I don't think that there has been drastic improvement by just starting testosterone from some of the functions in the myotonic dystrophy and from based on the studies. But I mean, if you have low testosterone, you're going to feel more tired. You're not going to feel as good. And so a little bit of a testosterone replacement can go a long way. But it does suppress sperm count, and that's why I think discussing when to start testosterone and whether or not you want to further investigate before you do that and have a discussion about the pros and cons is really important.
Great. Thank you so much, Dr. Merchant. I don't see any other questions. So if everyone could just stick with me for just a minute, I'm going to wrap it up. But thank you again, Dr. Merchant, for your time, expertise, and everything you do for the community.
Thank you.
All righty. So again, just I wanted to thank our speakers for being with us today. And as a reminder, our virtual learning series continues tomorrow from 3 to 5:30 p.m. Eastern Time, where we will be covering symptom management, physical therapy, and we will also include a patient advocacy panel to hear directly from the community. But for now, we want to hear from you. Well, what did you like about today's program? What can we do differently in the future? Please fill out the brief survey that will pop up right after this webinar. Your feedback is important to us. If you have any questions, are looking for support or resources, please contact the MDA's Resource Center at 1-833-275-6321 or via email at resourcecenter@mdausa.org. Last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as the latest research. Please scan the QR code with your smartphone or visit the link in the chat. Thank you again to today's speakers and to everyone who attended. This concludes today's portion of the virtual learning series, and we hope to see you soon.